you. I'd like to thank the organizers for inviting me to discuss some strategies and potential for siRNA and ASO combinations. Here are my disclosures. So I'm going to keep this relatively high level because I think a lot of it will be in the discussion. And we've heard a lot from the earlier speakers on some of the data and various strategies. But I want to reiterate that what we've learned so far is that if you focus solely on the virus, you're unlikely to get meaningful rates of functional cure. And so you really need a therapeutic approach that not only targets the virus, but also enhances the immune response of the host. And so here, my talk is about ASOs and siRNA, and these two classes of agents, while similar, are not identical, but they happen to target all three of these points of improvement for response. So they both reduce viral proteins, and we heard earlier today that surface antigen and other viral antigens are really important in promoting the immune evasion and facilitating viral persistence. So it's really important to degrade the viral proteins, and both ASOs and siRNAs do that actually very well. What we don't focus on a lot is that they both actually reduce viral DNA levels. And so a lot of the studies that we're doing now, we enroll patients who are on background nucleoside analogs, and so we don't really care that much about the viral replication. But data from the studies, for example, the GSK ASO, bepirovirsen, where we had treatment naive and patients not on nucleoside analogs, clearly show that the drug on its own can reduce viral DNA. Same thing for the siRNAs, they also can reduce viral DNA, and this may be an important aspect of achieving cure because you're preventing rounds of new infection. And as we know, nukes don't completely eliminate viral replication, so it's possible that the addition of these agents could further reduce viral DNA. This is just a hypothesis. And then lastly, we know that these drugs actually also stimulate the immune response. I think you've heard from Ed earlier that both the siRNAs and the ASOs do this, although they probably act in different places. So Ed talked about the fact, particularly the Arbutus data, which nicely showed that the siRNA can act on adaptive immune response, whereas I think the GSK group has really focused on innate immunity. This is not to say that bepi can't do anything with adaptive immune response or siRNAs don't do anything with innate immune response, but probably their main focus in their immune system are different. So this really sets up a situation where it makes sense to at least consider combining them in some way because they have similar actions, but they have some actions that are different. So again, just to hit home the point that they don't act in exactly the same way, you can see that the ASO really focuses its mechanism of action, at least the primary mechanism of action, through RNase H, and the siRNA, the primary mechanism of action is through the RISC complex. Another thing when you think about why you would combine agents is, do they have orthogonal methods of action? And so you'll notice that the siRNA primarily focuses in the cytoplasm, although there is some data in the siRNA literature that there may be some effects of siRNA in the nucleus. But for ASOs, it's predominantly in the nucleus where the action happens, although we also see action in the cytoplasm. So it may be that by combining these two, you're accessing mRNA transcripts that are not accessible to the other agents. And the other thing that I will point out is that the method of where they target their site of action is not just on the hepatocyte. So siRNAs right now are delivered through GalNAc conjugation. That seems to be very efficient, and we moved away from LNPs. But if you target the hepatocyte, you may be missing out on the immune component, at least in some respects. And we've nicely showed at GSK that when we had both an unconjugated form and a GalNAc conjugated form, the unconjugated form actually worked better. And we hypothesized that it may be giving you access to extra hepatic dendritic cells, resident macrophages, and stimulating PRIs, pattern recognition receptors. So these are some theoretical reasons why you may want to combine these two agents. So if you're going to combine these two agents, really there are three ways of doing it. So the first way is to dose them concurrently. And when I say dose them concurrently, you can start them at the same time, or you can stagger them to some extent, but essentially you're giving them largely together. The other way to do it is to do it sequentially, where in the second one, you dose the ASO first, and then followed by the siRNA, or you can dose the siRNA first and follow with the ASO. The question is, as I think Kerry mentioned earlier in his talk, you really don't have resource to do everything. So I know people think, oh, pharma, unlimited resource, surprise. You don't have resource to do everything. So you have to actually choose a strategy. So what is the advantage of concurrent dosing? Well, the advantage of concurrent dosing is that you may potentiate the effects of both at the same time, which is nice. And potentially the treatment duration is shorter. However, you need to think about safety issues due to potential adverse effects and overlapping toxicities. You also have to talk about, you're giving a lot of oligo load to the cells, and this is not something that I think clinicians think about, but in drug development, toxicology, that is something that you actually have to think about. The other thing is, if you're going to do this type of strategy, you need to think about when is the best time to do the strategy. Is this going to be your strategy that you do out the gate when they say, if you succeed, you're great. If you fail, you're shut down? This may not be the strategy that you think is the best strategy before you learn a lot about the individual agents. So I would caution people, if you're going to be really aggressive about an approach, to really consider some of these other issues. The other thing to consider about, again, this is more of a drug development issue, but it is important for you, is in terms of your development plan, combination toxicities. I mean, there's a lot of things that you have to think about in terms of being able to prove that it's actually safe to do these things in combination. And that can be very difficult to do until you have more mature data. So that's one reason why you don't see a lot of initial combination therapy in early studies, is you simply don't have a lot of data to convince ethics committees, regulatory agencies, and yourselves that it's safe to do so. So I just want to point that out for all the investigators who ask, why don't you do this? So ASOs, the second strategy is to do an ASO first, followed by an siRNA. So we've nicely showed that ASO like Bepi can really reduce surface antigen and get you to surface antigen loss. But we do have a relapse rate. So if you follow that by an siRNA, it's possible that the siRNA prevents the relapse. And that may be because you're cleaning up any residual transcripts that are not accessible to the ASO, or you're triggering other aspects of the immune system, adaptive immunity, particularly if we focus on innate immunity. And then if you do the siRNA first, followed by the ASO, that's another strategy. And you can see nicely from the siRNA data, siRNAs are very homogeneous in terms of being able to reduce surface antigen to low levels in almost everyone, but they're not good at getting to surface antigen loss. There is that plateau that we don't really understand. And so if you follow this with the ASO, it may be, again, you're accessing areas of the cell or immune system that are not accessed by the siRNA, and that might be able to get you over the hump. So in summary, we hypothesize that, again, like others, that you really need to target aspects of the life cycle, but don't forget the immune response, because these are necessary for functional cure. Both of them do this very nicely in different ways, and therefore you can give them together. Since Ed mentioned this morning, I would like to say that we have this Be United study that we're calling. It's a phase 2B study that we've just initiated that's actually doing exactly what we talked about. So we're enrolling patients to test the hypothesis that if you reduce surface antigen with an siRNA first, is it the same as doing it naturally? Or even if it's not the same, and I suspect it won't be the same, does it matter to an agent like Bepi? So those are really good questions, important questions to answer, and hopefully this trial will be something that can answer that. And then lastly, don't forget to check out this poster. We have more information on our modeling efforts of how an siRNA and a Bepi can be given together. Really nice mechanistic model from our PKPD group. So please check it out at AASLD.
Thank you very much.